Hi everybody. I will share you two cases in which percutaneous coronary intervention for circumflex artery have been performed. This is the first case I performed this procedure. This is an non-ST segment elevation myocardial infarction. Echocardiography showed inferior hypokinesia, and this is total occlusion of the RCA. We first tried to perform reperfusion in RCA. This is AR1 guiding catheter. When it was difficult, we used hydrophilic guide wire. We crossed the lesion, but normal balloon couldn't be delivered to the lesion. We used CTO balloon. This is 1.2 millimeter balloon. But we realized that it was a non-dominant RCA artery. And we tried to check coronary anatomy because RCA shouldn't be the guilty lesion. And we realized that there is overbranching in the dominant circumflex artery, and there may be total occlusion in distal circumflex. We were first suspected septal artery as a guilty lesion, but was a tiny branch. Now we will check distal circumflex artery. First attempt wiring, it is not a good position. We tried another position. This is AP cranial image, and this is another access, but we are not sure we are in. This is a good access, but unfortunately there is no antegrade flow, there is no retrograde flow, and we don't have intracoronary imaging, and so we should be very careful for predilatation. We used this balloon 1 atmosphere. Unfortunately, only 1/3 of the balloon is dilated. Distal 2/3 is not dilated. And then we deflated the balloon and checked angio. And we realized that wire was in a tiny branch. If we dilate it at high pressure, it would result in coronary rupture. We should be very careful if we are not sure about the position of the wire. So we redirected the wire again, but only 1 atmosphere dilatation of the balloon was enough for antegrade flow of TIMI1 antegrade flow. And we directed the wire and we made balloon dilatation. There were many branches in that area. We didn't apply stenting procedure here. It was a tiny branch and overbranching area. We might lose some branches here, and antegrade flow was good. Patient said my chest pain is gone. There was no chest pain at this moment, and we finished the procedure in this patient. And it shows that in case of dominant circumflex, we should be very careful about the distal circumflex artery. At the beginning, there was marked overlap with LAD and overbranching circumflex artery. At first, we couldn't realize there was a total occlusion in the distal circumflex, and we first suspected septal 1 branch or RCA branch was a guilty lesion, but after reperfusion of the RCA, we realized that it was non-dominant. It was not responsible for the symptoms and clinical findings. And then we checked distal circumflex and finally found the guilty lesion and reperfused the culprit lesion. And we should be very careful if we are not sure about the position of the guide wire. We can use only 1 atmosphere dilatation of the balloons on small balloon in the area and check again. And this is the second case. In this case, coronary artery is very curved, and you see distal circumflex branch. There is a slow flow there. This is not my case. There is slow flow in LAD, but it is much more in this OM branch. It should be probably guilty lesion. I don't know the clinical presentation of this patient. I will explain on the angiographic images, but as you see, RCA is dominant RCA, big RCA. In this case, we would not expect big circumflex artery, but my colleague tried to find a vessel in the distal circumflex, but actually culprit lesion is obvious in this patient. And in case of dominant RCA, circumflex artery is not so big. It is this much. As you see, this is the culprit lesion. The only need was stenting of the OM branch here, but my colleague thought that there was a big branch there, tried to recognize, but as you see, the tip of the guide wire, it is very freely floating. Now this is predilatation. You see, distal 1/3 of the balloon is not dilating. You couldn't reach high pressure. You shouldn't do that. And this is rupture now. Flow in the arm branch is decreased. But unfortunately, my colleague thought that this is a big branch, although it was rupture, and there is opaque remaining in the pericardium or wall of tiny branches. I don't know, but I think that there is no big branch here because RCA is dominant. This is obtuse margin 3 branch, on the right side, and it is probably the culprit lesion. But my colleague misregard this as a big artery, although it was rupture. And he is confused about this image. I was not in the cath lab. I'm only discussing angiographic images. I don't know the clinical presentation of the patient, but actually, after dilatation of the circumflex before the bifurcation, perfusion in the OM branch increased. It was enough in this patient. This is previous angio. There is no big branch here, only small artery. Unfortunately, culprit lesion was regarded as unknown artery. Unfortunately. This is a real culprit lesion overlapping with the LAD. Yes, this is culprit lesion. Flow in the OM branch is very slow. It comes after perfusion of distal LAD. Now this is second wire, body wire, and you see the tip of the wire is very free. The continued predilatation makes rupture bigger, and you see wire is not in the proper position. It is probably in the pericardial space. Now, unfortunately, it's just stenting procedure now. We're not sure we are in. You see, you see here resistance in between, in the middle of the stent. There is probably the small branch, and full dilatation is in the pericardium distally. Now it is rupture, obvious rupture. This patient suddenly developed cardiogenic shock. You see tachycardia now. We can save this patient without surgery. Unfortunately, this patient had undergone surgery for pericardial tamponade. We have a chance in this situation. We can redirect the wire into the OM branch and dilate stent struts, and we can put graft stent from circumflex to OM, and we might close the ruptured area as a side branch. I believe it will prevent the tamponade and surgery in this patient. We may put graft stent from circumflex to the OM branch to prevent tamponade in this patient. Unfortunately, They tried pericardiocentesis, they failed, and surgery was performed for cardiac tamponade in this patient. What are messages in both cases? Before predentation or delivering devices, we should be sure about the position of the wire. Wire should be in the true lumen and in the big artery. Before dilating balloon, if we are not sure about the position of the wire, we may use only 1 atmosphere dilatation, and we may pull back balloon and check again angiographically, and we may redirect the wire and dilate the proper artery. And in the second case, if you see big RCA, you will not see big circumflex. So if you see OM1, OM2, OM3, this is OM3. After OM3, circumflex would be on a very small branch. This study, in case of dominant RCA or codominant RCA, you should not dilate or perform intervention